Welcome to another video by Royal Christ College, and today we're going to be talking about Parkinson's disease. You follow us on our YouTube at Royal Christ College or on our Instagram at Royal Christ College. So, to follow more in our neurology section, you can learn more about Parkinson's. Parkinson's disease, as you know, is a neurodegenerative condition, so it involves neurons and degeneration. It is a progressive condition, meaning over time it usually worsens and irreversible, leading to increased disability. So on screen you have the brain, you have caudate, which controls the integration of spatial movement so you're aware of what's around you. Then you have the putamen. Collectively, these make up the striatum. The putamen regulates movements as well as reinforces implicit learning. So just to put it out there, this is known as a striatum, and this will become important when you learn about the dopaminergic pathway. Now let's look in and dive in a bit more detail. So on screen you have the caudate nucleus, you have the thalamus, you have the putamen, and finally you have the globus pallidus. Underneath all this, if you take a sliced cross section, you would find a very specific area known as the substantia nigra pars compacta, and this is what we're interested in Parkinson's disease because this is the area which is most greatly affected. The substantia nigra pars compacta is in direct communication between the globus pallidus, the striatum, which is the caudate, and the putamen and the thalamus, via the substantia nigra or nigrostriatal pathway. And this pathway is usually done by the dopaminergic neurons, i.e., neurons that release dopamine. So, dopaminergic pathway you can see on the screen. Substantia nigra on the screen, you can clearly see it's run by dopaminergic regions. So you know that these neurons release dopamine at the end of the synapse. And in Parkinson's, simply there's a loss of these dopaminergic neurons, which leads to decreased signals over time. And so you can imagine when there's no communication between these, there will be a decrease. On histology, you can see a normal person's substantia nigra is more dark because of there's abundant neurons compared to someone with Parkinson's. There's a loss of dopaminergic neurons, and in histological neurons, in microscopically within these dying neurons, you would find a histological entity known as Lewy bodies. So on gross findings, i.e., what you see really is usually a pallor of substantia nigra or the locus coeruleus. And then microscopically, you would find Lewy bodies. Lewy bodies are basically simply alpha-synectin molecules, and they're usually known as intracytoplasmic eosinophilic inclusions. So after the dopaminergic neurons die, they end up forming what's known as Lewy bodies, and they first usually tend to appear in the pons and the medulla, then followed by the cerebral cortex. Now, what are the causes? Well, the most cases are sporadic, so there's no cause, but genetic factors can be included, especially if you have a family who has Parkinson's, so it's autosomal dominant, and it's also said to be autosomal recessive. It's linked to enzymes LRRK2 as well as VCHL1, and it's more common between the ages or in late ages between 60 to 80, and females have a greater predilection. Affects more countries away from the equator, so maybe vitamin D also, and sunlight has some sort of predilection. The clinical features can be remembered by a mnemonic TRAP: T for tremor, R for rigidity, A for akinesia, and P for posture and imbalance. Tremor causes shaking and unilateral first, then it becomes in both sides, so it's unilaterally first. Rigidity leads to stiffness of limbs, necks, and trunk, or known as lead pipe rigidity. Akinesia is loss of impairment in power of voluntary movement, leading to gait, and you can imagine the posture. So we have our typical man who's diagnosed with Parkinson's. Usually they have a masked facial expression. There's known as lead pipe rigidity in the elbows. There will be trembling of the extremities, especially the hands, of unilaterally at first and then of both. There'll be gait and shuffling in the way they walk, and there may be flexed hip and a stooped posture. So if you find any of these with an especially elderly patient, think Parkinson's disease. Let's talk about the disease progression. So bring out the graph where on X we have time and Y we have disability. So Parkinson has usually a time where it relapses, where it gets better with medications, especially levodopa, as well as brain stimulation. But over the years, it usually progresses in a worse state between 10 to 15 years, eventually leading to motor slowing and near immobility. Sometimes the death tolls are due to intercurrent infections or frequent falls, which lead to pelvic femoral neck injuries and breakages between, and leads to aseptic necrosis. Initially, medications such as levodopa initially respond, which is why you have the relapse, but then does not always slow the progression. So we bring back our model. So remember, we have a stooped posture, lead pipe rigidity, tremors, usually unilateral, shuffling and gait, short stepped gait. We also have flexed and masked face, flexed knees, and which means they can't sit or anything, and it becomes completely a problem. So neurologically, they might end up suffering from decreased appetite and depression. Now, the treatment FDA approved is dopamine precursors, which is a gold standard levodopa. Dopamine agonists include bromocriptine as well as gabagoline, and we also have MAOB inhibitors, rasagiline and selegiline. But the gold standard is levodopa. Usually, you can also do deep brain stimulation, but as of now in the world, there isn't much treatment. So, thanks for watching this video. Hopefully, this makes some sense, and thank you for watching. Please subscribe to our channel.